Okay, hi. This is going to be your Module 4 voiceover PowerPoint on emergent renal, gastrointestinal, and reproductive disorders. This is through your FA Davis. There's many different chapters that it's covering, and you can find these chapters in your module. So to start off, we're going to talk a little bit, just a quick overview of anatomy and physiology of the renal system. Of course, this includes our kidneys and then ureters, bladder, and urethra. And basically the functions, as you are probably well aware of, the renal system has to do with the excretion of waste, regulation of fluid and electrolyte balance, your acid-base balance, regulation of your blood pressure, secretion of erythropoietin for red blood cell formation, and activation of vitamin D. So that's kind of a quick overview of the functions of your renal system. So as I said, your renal, this has to do with the formation of urine and excretion of waste. Like I said, your fluid and electrolyte balance and your acid-base balance, as you just learned about ABGs, you know that kidneys are your HCO3, your base, and helps to regulate that. Also has to help with hormonal functions like the production of renin that is used to help regulate your blood pressure. And then, like I said, erythropoietin for red blood cell formation and vitamin D. It also has to do with the release of bradykinin and prostaglandins. So we'll just do a real quick overview. You guys have already learned about this, but with your antidiuretic hormone, this slide just kind of shows how when your body is dehydrated, you have decreased volume status, so your sodium levels increase. This causes an elevation in your blood osmolality and stimulates the whole process of being thirsty and needing to drink more fluids. This causes your posterior pituitary to release ADH, the fact that you have low volume in your body. So it causes your posterior pituitary to release ADH, and as you know, that's antidiuretic hormone. This antidiuretic hormone, if you think diurese, you're getting rid of fluid. Antidiuretic, that means stopping it. So it's helping your body hang on to fluid. So it stimulates your kidneys to increase water reabsorption. And by increasing water reabsorption, then that what it's hoping it does is that it helps your body hang on to fluid. By doing this, then you have a reduction in your urine output. This next slide kind of talks about the whole aldosterone's secretion system and how this comes into play with your kidneys as well. If you have, if your body senses hypotension or low blood pressure, which would be because of maybe a low volume in your body, then what happens is, or this hyponatremia, what happens is that it stimulates your adrenals above your kidneys there to secrete aldosterone. And I know in pharm we talked about aldosterone being a very potent water conserver. So that's going to help you hang on to fluid and hang on to sodium. So this hypotension or low blood pressure stimulates your kidneys to produce renin and angiotensin, and this also stimulates the whole production of this aldosterone for your adrenals to kick out this aldosterone. So by doing this process, then it has your body increase sodium reabsorption. Like I said, aldosterone is a potent water conserver. Where water goes, sodium follows. So, and vice versa. So you have this increase in sodium reabsorption. Therefore, you have less sodium in the urine, and therefore less water in the urine. And by doing that, by hanging on to the sodium and the fluid, then it in turn increases potassium secretion in your urine. And then your third mechanism that kind of helps with this volume is your renin angiotensin aldosterone system, or your RAS system. We talked a lot about this as well. So as you can see here, when you have decreased blood flow or volume or blood pressure, we already kind of talked about, your kidney kicks out renin, your liver is always secreting angiotensinogen, and when the renin mixes with the angiotensinogen, then it produces angiotensin 1. Your lungs then kick out ACE and change the angiotensin 1 to angiotensin 2, and that's your potent blood pressure control. So your angiotensin 2 then affects your hypothalamus, your cardiovascular system, and your adrenal above your kidneys there. And you can see how this just keeps going down. So the angiotensin 2 is your vasoconstrictor to try to hang on to things to bring up your blood pressure. So your hypothalamus, it stimulates your hypothalamus to think that it needs to drink more. It stimulates your cardiovascular system to vasoconstrict, therefore raising your blood pressure. And then you can see here your adrenal cortex kicks out aldosterone, which causes the sodium and water retention, which everything in the end there leads to an increase in your blood pressure. Back on this, well, we can kind of talk about it here. There are certain blood tests that will be done for your kidneys, and we'll go into that more as well, just to see the function of your kidneys. So blood tests, they'd be monitoring your BUN and your creatinine, your uric acid, electrolytes, bicarbonate. And then with urine tests, we know that we can do a urinalysis, culture and sensitivities, creatinine clearance, things like that. And then a lot of times they can do sonography or ultrasound. This will be like a non-invasive way of looking at your kidneys. And then, of course, on down to x-rays of your kidneys and your ureters. They can do KUBs of your bladder. They can look at the anatomy of the renal system, the structures, to see if there's masses or obstructions or calculi, like stones. And then they can also do contrast x-rays and renal ultrasounds. Okay, so renal failure, this has to do with the partial, it says there partial or complete inability of the kidneys to filter waste products and water from the blood through glomerular and tubular filtration. So you have acute kidney injury, or AKI. This is rapid, acute. In most cases, this is a reversible form of kidney injury. And then as we go to chronic kidney disease, this develops more slowly, and it can occur over months to even years. So we'll start with AKI. With acute kidney injury, like I said, this is acute. You have a rapid loss in renal function. It goes on to talk about how you can have this progressive azotemia and an accumulation of your waste products there, your urea or your nitrogen, which are the waste products in your kidneys. Oliguria may be present. That's urine output that's less than 400 mils per day. Uremia may be present, and it says there's different phases within your acute kidney injury, and then there's different what do I want to say, different levels where the acute kidney injury can happen. So the pre-renal, intrarenal, and post-renal. Those are the different levels of injury that can occur. We'll go over that. And then your 4 phases of AKI. You have your initiating phase, your oliguric phase, diuretic phase, and recovery. So the initiating phase is your onset. It's at the very beginning phase of insult, and this continues until signs and symptoms appear. This can last anywhere from hours to days, and it's usually something pre-renal that triggers this. Then you move into your oliguric phase, and this phase is where your urine output starts to drop, and it says drops below 400 mils per day. So oliguria in this phase, this is what characterized by urine with a fixed specific gravity. It usually says between 1.007 and 1.010, and it has a high sodium concentration. So talks about things that complicate this is the fact that 50% of patients may not exhibit oliguria. So this allows for more damage to occur before the disease is detected. So not always does this happen. Also in this phase is when you start to see your rise in your BUN and your creatinine. You might start to see an acidosis happening, fluid overload, things like that. This phase may last up to 14 days or longer, just kind of depending. And then it does go on to say that the longer the oliguric phase lasts, the poorer the prognosis, and that kind of makes sense. Then you move into your diuretic phase of AKI. The diuretic phase occurs once the cause of the acute kidney injury has been corrected. Then it says there's an osmotic diuresis that happens. Urine output can increase from 1 to 3 liters to 3 to 5 liters a day. So they could have severe fluid loss because of this increased urination, and then that would lead to dehydration and more electrolyte imbalances and causing more problems. This can last 1 to 3 weeks. And then your recovery phase is your last phase, and it talks how this begins when the kidney begins to return to its regular function. During this stage, it says that the GFR increases up to 70 to 80% of normal. So fluid and electrolyte begins to normalize, and this phase can last several months to even a year. Okay, so this is just another slide. I kind of talked about how there was pre-renal and intrarenal and post-renal. This is a good slide that kind of shows how those occur. So you can see there your pre-renal is where it kind of shows how you would have a reduce in renal blood flow. And then the number 2 there, it says your intrarenal. This is direct damage to the actual renal system. And then number 3 there, post-renal. This is like a mechanical obstruction of the lower urinary tract. So it's an actual obstruction. Okay, so pre-renal. So this is the most common. This has to happen due to external factors, like maybe there's something that's causing blood flow to be reduced to the renal system. So things like hypovolemia, decreased cardiac output. It says here decreased peripheral vascular resistance, which would be like a lower blood pressure. If you could think about that high hemodynamic change there, and a vascular obstruction, which would cause decreased blood flow, can affect the circulation. So you would have a low urine output, your BUN and creatinine, your kidney function test then would begin to rise, and you would have an inability to conserve sodium. So again, pre-renal, this is the most common cause of AKI, result of like external factors. So an example would be like if somebody was hiking and became very dehydrated, um, then they would have low blood pressure, which would be low blood flow to the renal system and cause this pre-renal injury. Another example could be maybe somebody having an acute myocardial infarction. We just got done talking about that and how um, having this injury to your heart could lead to a shock-like state even. This would be decreased perfusion, and that means decreased perfusion to your kidneys. A lot of times when they see a decreased urine output, like less than 30 mils per hour, this is what they watch to see if there's like worsening in renal function and perfusion. So acute myocardial infarction. That's another example. Or maybe a trauma patient. Somebody has some type of car accident or some type of trauma that happens and has blood loss. Then that would be decreased volume, which would lead to hypotension, and this could cause a pre-renal injury. Intrarenal. This is direct damage to the renal parenchymal tissue. Um, you have impaired nephron functioning. This would be like a direct assault to the nephron that compromises the perfusion and filtration of waste products. So the functional, an assault to the functional unit of the kidney. So this damage occurs as like if you have prolonged ischemia. So prolonged ischemia or blood flow may be exposure to nephrotoxins like aminoglycoside antibiotics, or maybe um, even Lasix doses. If they give higher Lasix doses, furosemide doses, even though you can give furosemide with some, mild renal failure, they would have to watch that, because if this continued, you could actually worsen somebody's renal failure and cause this intrarenal kidney injury. So these increased Lasix doses may be given at higher milligrams, maybe twice a day or something. Another example could be contrast dye that they use with imaging studies. If you have hemolyzed red blood cells, um, these bigger blood product or blood cells can cause damage to the kidneys. Myoglobin, if you have necrotic, like if you have someone that goes into rhabdo or something, where they have a wasting of the muscle there and production of myoglobin, these are big cells that can clog up the kidneys and cause this intrarenal damage. So some of you may hear of acute tubular necrosis or ATN. ATN, this is an intrarenal condition caused by ischemia, nephrotoxins, pigments, says that it accounts for 90% of all intrarenal cases. Okay. So let's move on to postrenal. So with postrenal, like I said, there's a mechanical obstruction of the lower urinary tract. So in the ureters, the bladder, the urethra, and as the urine is leaving the kidneys, then the flow is obstructed at some point in the ureters. This reflux begins to happen, and this impairs kidney function. So something causing an obstruction could be having BPH, or somebody that has a TURP procedure, maybe prostate cancer, kidney stones. It could be trauma, like a clot with trauma, even tumors. So if they don't get rid of this, whatever's causing the obstruction, then they can begin to have acute kidney injury. Okay. So some manifestations that you may see with acute kidney injury include volume overload. Um, that kind of makes sense. They could have decreased urine output. Sorry, I was doing something real quick. They can have decreased urine output, swelling or edema. If their kidneys aren't working as well and they're starting to have this buildup, you can see how they can go into pulmonary edema. We talked about that last module. Also, you've had that in the past. That's when they have that pulmonary edema or the frothy red pink tinged sputum. This can cause shortness of breath. It can back up into heart failure. You can see how you can get JVD, hypertension, dysrhythmias. So the list here goes on and on. You guys can read all this. One big thing that can happen, though, is you can have elevated potassium levels, and hyperkalemia, as we know, is a medical emergency because it can lead to cardiac arrest. So that is your big thing with kidney failure, is your electrolytes. You have to really think of that, about that potassium. So the primary goals include in the management of this hyperkalemia is we need to stabilize the myocardial cell, the membrane, make it so it's not so irritable. And the way they do this is they give IV calcium gluconate or calcium chloride. This helps calm down the heart. So I always just think calcium helps calm down the heart, CAL, calcium, calm. Calcium chloride's more concentrated than the gluconate. Gluconate is, but they do either or. After that happens, then a lot of times they will administer what what they do is they give IV glucose, and then they will give IV insulin. So the insulin pushes the potassium and helps move it back into the cell. And then, of course, because we're given insulin, that's why we're given the glucose. So you give IV glucose followed by IV regular insulin. If you remember, regular insulin is the only insulin you can give IV. Again, I said that the insulin facilitates this movement of potassium back into the cell. And the glucose is so the patient doesn't become hypoglycemic. Another thing that they can do to help move this potassium into the cell is they can give albuterol. and a breathing treatment, an SVN treatment. So administration of albuterol, which is a beta agonist. It causes bronchodilation. This also helps move potassium into the cell. Another thing that can be done, so usually what you'll see them do is give the insulin, like 10 units of IV regular insulin, and then they, along with this glucose, IV glucose, and then they also get the calcium chloride. So a lot of times they'll give those three together. Another thing they can do is give bicarbonate. This helps with the exchanging of hydrogen ions and potassium ions, again, moving potassium into the cell. Another treatment that they use to help lower potassium levels is by administering Kayexalate, or the generic name is polystyrene sulfonate. And I would recognize the name polystyrene sulfonate. This binds with potassium, helps the patient basically eliminate it in the stool. There's a lot of fluid shifting that happens with that. Another treatment is giving IV Lasix if they're still able to void, because as we know, that is potassium wasting. It's a loop diuretic. Therefore, you eliminate potassium in the urine. And this is pretty much the only time you're going to see them do an emergent HD run or hemodialysis run, is if that potassium level is too high. They will emergently dialyze somebody if nothing else is working. So that's another way of trying to do something about hyperkalemia, is emergent hemodialysis. So some other things that you would see for laboratory values, we talked about the BUN and creatinine. This would be increased if somebody was having renal failure. We talked about because of the reduced clearance, your potassium, I just went over that. Because of reduced clearance, your sodium. This would be decreased because of the kidney's inability to conserve sodium because it's impaired. Hemoglobin and hematocrit, this would be decreased because the kidneys decrease production of erythropoietin. So if you have a kidney that's not working right, then it's also not going to be producing erythropoietin. So your H&H would be low. Calcium and phosphorus. Calcium is decreased because of the kidney's inability to activate vitamin D. You have to have vitamin D and calcium have to go together. For the body to hang on to calcium, you have to have vitamin D. Phosphorus is increased because of the release of parathyroid hormone, and that's in response to the low calcium. Your parathyroid is the hormone that tries to release more calcium. So it also does that with your phosphorus as well. So, but if you don't have the vitamin D, you can release calcium all day long. Your body's not going to hang on to it. So you have this hyper functioning in your parathyroid hormone of your parathyroid, releasing all of this parathyroid hormone because you have low calcium. And then your arterial blood gas, you'll have a metabolic acidosis. So just think the way, remember I said when we were talking about ABGs, that your acid is found in your urine. And if you're in renal failure, you're not peeing out the acid. So you're hanging on to it. So metabolic acidosis due to inadequate clearance of acid, increased loss of bicarbonate, and increased production of non-volatile acids. Okay, So, some treatments like we've already talked about. So medications, we have our diuretics, our loops, and those are anything that end in "ide." So your furosemide, your bumetanide, those are your loop diuretics. You also can be using mannitol, which we use to treat, it's an osmotic diuretic. So it'll pull fluid into the vascular system. That's used to treat fluid overload. You should be avoiding toxic agents like contrast dyes. And then you would be using isotronic crystalloids like normal saline, half normal saline. Usually they don't use LR or lactated ringer because it does have potassium in it. So they'll usually avoid lactated ringer with kidney failure. So if you think about your diuretics, there are certain diuretics that they would avoid, and that would be your potassium sparing diuretics like spironolactone. It would be because potassium is so dangerous, it would be extremely important to educate your patient about the signs and symptoms of hyperkalemia. So things that kind of go along with that would be restlessness, weakness, tingling in your fingers, abdominal cramping, things like that. A lot of times if people do receive or patients do receive contrast dye, they need to monitor their serum creatinine levels for about 72 hours post dye to make sure that they're coming down. This kind of goes into dialysis again. It says here indications for dialysis include severe volume overload resulting in heart failure or respiratory distress. They still won't do it emergently though for that. Elevated potassium level with EKG changes, that will get an emergent dialysis. Severe metabolic acidosis, they will do dialysis for that and just clear. And altered mental status, pericarditis, pericardial effusion, cardiac tamponade. And we're going to go a little bit more into dialysis as we keep going here. Okay, so nursing interventions. These kind of speak for themselves. So vital signs, obviously, we're going to be watching because they could be having maybe hypotension or tachycardia. Um, maybe initially at first, and then as the process continues, because they start having fluid overload, they might even have hypertension. So we got to be watching that. Urine output. This is going to, initially it's decreased because of the decreased circulating volume. Later, it will be decreased because of the impaired clearance. So we would want our urine, we want urine specific, I'm sorry, you would want your urine to be 0.5 to 1 mil per kilogram per hour. So think your urine output, you would need 0.5 to 1 milliliter per kilogram per hour. Okay, so we'd also be managing our fluid balance. We said initially we may be giving fluids to see if we could make sure we have adequate circulating volume, but later we may be restricting fluids to prevent fluid overload. We'd be giving diuretics as we need to relieve fluid overload if it was working. Um, doing whatever we need to administer potassium lowering therapy needs that we've already talked about to avoid lethal dysrhythmias. We'd be weighing our patient every day. Increased weight reflects in fluid overload. So we need to weigh our patients every day. Skincare because of the decreased tissue perfusion because of edema. And then food intake. So we definitely want to monitor our intake to make sure that the patient has a good nutritional status so they can have a good healing process. But we definitely would be restricting our diets with making sure that the patients have reduced sodium and reduced potassium in their diets. So again, with our diet, we want to make sure there's enough calories. We don't want the patient to start to go into catabolism, which would cause even worsening of our electrolytes. But we want to make sure that we restrict or give low potassium and low sodium, and that these are restricted to prevent hypertension, CHF, cardiac problems, edema, things like that. Okay, let's go into chronic kidney disease. So this is a progressive, irreversible loss of kidney function. It's pretty much characterized by a slow increase in BUN and creatinine. There's a lack of, a lot of times there won't be any symptoms at first until the process is so far advanced that there's very little renal function remaining. Um, like I said before, there's this lack of erythropoietin because of the kidneys. That's where that takes place at. So if the kidneys are not producing erythropoietin, then we are not able to stimulate red blood cell production. So these patients become very anemic. So a lot of long-term diseases or medical comorbidities that help or that can lead to advanced kidney disease would be hypertension, diabetes, lupus, PKD, pyelonephritis. You could also have chronic kidney disease happen because of poorly managed AKI. Advanced stage kidney disease is referred to as end-stage renal disease or ESRD, end-stage renal disease. And again, risk factors, diabetes, hypertension, hyperlipidemia, smoking, recreational drug use, obesity, NSAIDs. So some manifestations of chronic kidney disease, a lot of times you'll see patients with hypertension have on high blood pressure because they have this, they're retaining fluid. They can a lot of times present with heart failure, pulmonary edema. We talked about our altered potassium levels being too high. They can have GI symptoms, neurological symptoms. They're not clearing their waste, then they can become very altered neurologically. Metabolic acidosis and endocrine reproductive dysfunctions, and also chronic anemia. So if you think about assessing these patients, then these patients you would be watching for um, increased fluid. So JVD, crackles in their lungs, you'd be hearing that. Maybe because of the potassium or an electrolyte imbalances, you'd have these dysrhythmias because of the decreased production of erythropoietin and the chronic anemia. They would have pale skin, decreased perfusion. This next slide kind of shows everything that I just kind of talked about already, but you can see how it kind of goes into chronic kidney disease, how it leads to sodium and water balance, potassium, elimination of nitrogen waste, and you guys can follow that down and see how it affects everything. It's just another look at that slide. It's kind of nice though to see. I like to follow it. That will help your understanding of the process. So with diagnosis, this is by having a consistently high creatinine level, decreased creatinine clearance, and presence of protein and albumin in the urine. There's a chart from your book that shows normal lab values and the values that you're going to see in renal failure. Your treatment is going to be anything, measures to remove the waste products, renal replacement therapies, like your dialysis, and treatment of hyperkalemia, hypertension, anemia, and dyslipidemia. So you can look through there and see the lab values that are related to renal failure and what you will see there. So once again, hyperkalemia, because it's so important. These elevated potassium levels can be lethal, and like I said, they need to be addressed immediately to avoid your patient from coding and dying, basically. We can clear these potassium levels by dialysis, or another thing that you can do is talk to your client about managing their diet, restricting foods that are high in potassium, like bananas, potatoes, things like that. If the levels are high, they need to use some type of medication therapy to reduce the serum potassium level. We talked about stabilizing the cardiac membrane using cardiac gluconate or, I'm sorry, calcium gluconate or calcium chloride. Anytime your potassium level is too high or even too low, but in this case, too high, it makes the heart very irritable. They can go into these lethal dysrhythmias. So calcium calms the heart. We would then give the IV glucose and then IV insulin to try to bring down the potassium level. A lot of times they'll do an albuterol breathing treatment. We talked about bicarb, anything to help move the potassium into the cell. We said that IV furosemide, if they're still voiding, could help clear potassium out through the kidneys and into the urine. And K-oxalate or the polystyrene, that medication helps bind with potassium, so they poop it out in their GI tract. So the polystyrene sulfonate. Okay. So this is just a slide that kind of talks about dyslipidemia and hypertension, different things that we use to help work or control and try to get under control dyslipidemia. There's your goals for your LDL. Remember your LDL, you want low. So below 100, your triglycerides should be below 200. You can give statins and fibrates to help lower that. And then for your hypertension, it says your target is 130 over 80. You can give diuretics, beta adrenergic blockers, calcium channel blockers, ACEs, and ARBs. But again, even with the ACEs and ARBs, it depends on how bad the BUN and creatinine is, your creatinine, because if it's too high, then they're going to be careful with that. Okay, so anemia, I've already talked about this because of this decreased production of erythropoietin. I think I've said this now probably 7 times. So everybody should get this correct if this is ever on an exam question. With this, they'll be given oral iron and doing blood transfusions. So that's why when you see patients receiving that have chronic kidney disease, receiving dialysis, a lot of times they will end up having to give blood transfusions because they are chronically anemic because of this whole process. Right, medication management. So you can have a decreased elimination of meds that can be delayed and lead to potentially toxic accumulations of meds in the system. So you have to be very careful about this. A lot of times dosages may need to be adjusted because of this. Some of the more common culprits there are DIG, certain antibiotics, pain meds, says Demerol is contraindicated. This is because it is metabolized to something different in the liver, which the kidneys excrete. So if serum levels of Demerol become elevated in chronic kidney patients, they can actually have seizures. They should be avoiding NSAIDs of all sorts. NSAIDs block the synthesis of the renal prostaglandins that promote vasodilation, and this can worsen the renal hypoperfusion. A lot of times they'll substitute acetaminophen for NSAIDs in patients with renal failure. Certain meds like the aminoglycosides, penicillin, tetracyclines, these are all nephrotoxic, so should be avoided. Certain meds are filtered out through dialysis, so you have to think about that when your patient is receiving dialysis. So that's something you can talk to your dialysis nurse about. Some nutrition, a lot of times they'll do dietary consults um, to help educate about nutrition. Uh, with renal failure, they restrict protein in patients with chronic kidney disease because of urea, nitrogen, and creatinine. These are the end products of protein metabolism. So initially, they'll be having a diet that's low in protein, low in phosphorus. And if they do that, hopefully they can slow the progression of the renal failure. If a patient starts dialysis, they can increase the protein intake a little bit because protein loss is high in dialysis. So interventions for chronic kidney disease. We'd be wanting to weigh our patients every day, especially before dialysis. These patients, if they have chronic kidney disease, will be receiving dialysis. So we would also be restricting fluids and sodium and trying to educate them so they do not miss their dialysis appointments. If they have a fistula for their dialysis, then there's different accesses. Sometimes you'll have someone that has a perm cath, which is a permanent catheter that's in their chest. Other patients will have fistulas. So if they do have a fistula, we would be assessing the fistula site every day, every shift. We would teach the patients to assess their fistula site daily. We definitely would be maintaining cardiac monitoring for a patient, especially because of the risk of hyperkalemia. Like I said, we'd be weighing the patient every day. Try to weigh them at the same time in the morning and then definitely before dialysis. We'd be teaching medication compliance. Another thing with fistulas, we want to teach our patients to not sleep on the extremity with the fistula. That's very important. And then, like I said, to not miss their dialysis runs. Okay, you guys can read the rest in the speaker notes there. All right, renal replacement therapies. We have hemodialysis and peritoneal dialysis. So hemodialysis, this is done in outpatient centers. They can do it in the hospitals. There are some home hemodialysis treatments that can be ran at home as well. Usually with peritoneal dialysis, this is performed at home, but they can still get, obviously, peritoneal dialysis in the hospital. There's also continuous renal replacement therapies, or CRRT. This is a type of hemodialysis that you need to be familiar with. CRRT, this is indicated for acutely ill patients. This is specifically really targeting also and helping to manage those acid-base imbalances and electrolyte levels. They do also use it to pull fluid. They use the CRT, or continuous renal replacement therapy, in hemodynamically unstable patients. So if you have somebody that's acutely ill, somebody who has hypotension, is on pressors, that's hemodynamically unstable. A lot of times those patients cannot tolerate the fluid and electrolyte shifts of regular hemodialysis, so they need this continuous renal replacement therapy. So the CRRT is ran nonstop by the nurse for days. It's continuous. So if you have like unstable vitals, like I said, like hypotension and they're on pressors, or trauma patients, things like that, that's when you're going to see CRT, or continuous renal replacement therapy. Okay, some complications that can occur because of hemodialysis, and this can happen during or even after hemodialysis. So hypotension. So hypotension's big. This can happen because of the rapid removal of fluid, or because of vasodilation. So a lot of times patients can display lightheadedness, nausea, vomiting. They can have seizures, vision changes. They could have chest pain because of this. There's something called dialysis disequilibrium syndrome. A lot of times this is the first dialysis is done, or when the patient first starts getting dialysis, they can experience this dialysis disequilibrium syndrome, and they can have seizures. So one thing that they do for this is their first dialysis, they do it a lot slower and less aggressively in removing fluids and solutes. So they won't pull very much fluid. A lot of times you'll see them do dialysis daily the first 3 days, and then after that they go to, every other day or every third day. That's why, to avoid this dialysis disequilibrium syndrome. So you see here that it can cause muscle cramps, headaches, nausea, dizziness, malaise. If it can cause all this, this is important things to teach your client to tell you about if they start to feel this. This is things they need to tell us about. So you would teach them if you start feeling a headache, nausea, vomiting, dizziness, you need to tell me right away. You can have altered platelet functioning associated because of the uremia that's happening and the use of heparin during dialysis. So you have a potential for bleeding that can occur. Sorry, I don't know where I got occurred. That can occur. Obviously, an infection could happen because we're entering, this is an invasive procedure. So systemic infection is a concern. They have a high risk of developing hepatitis B, hepatitis C, cytomegalovirus, HIV infections because of the multiple blood transfusion that happens. So they have a lot of risks. They have this dialysis associated dementia. This is a progressive, it says potentially incurable neurological complication because of long-term dialysis. So there's a lot of complications that can occur with HD or hemodialysis. Here's a slide showing an AV graph. This is your fistula, your AV fistula. So this is an option for dialysis. They have a prosthetic graft between an artery and a vein. So with these, it's important to assess these appropriately. Remember the priority assessment for an AV fistula is checking for a positive bruit and thrill. You check right over the top of the graft site. So we listen for a bruit and we feel the thrill. That's important to remember. You feel the thrill, listen for a bruit. The bruit is like a whooshing or rumbling sound that you can hear. You can also feel the thrill. The thrill is like a rumble that you can feel by placing your hand right on top of the graft site. And in your speaker notes, there is a couple of YouTube videos there that you can watch about that. So peritoneal dialysis, this is done with end-stage renal disease also. It's indicated for patients who want like a little bit more control. Maybe they have problems with having vascular access. Maybe they responded poorly to HD or hemodialysis, that maybe they have too much hemodynamic instability. Maybe they just want to manage their dialysis at home by themselves. It's a lot easier for them. They have their dialysate fluid, and then they have a catheter that's in their abdomen there. They will instill the dialysate fluid and let it dwell for so long, and then they will let it drain. The important thing is obviously if we're instilling fluid, their dialysate fluid, we would and letting it dwell in the peritoneum like that. We would want to teach the client to make sure that to warm the dialysate bag to body temperature. You could only imagine problems that could occur if they dwell cold dialysate fluid. So with peritoneal dialysis, again, there's continuous, automated, and intermittent. They kind of go over different, in your speaker notes, there are different types of continuous peritoneal dialysis or automated peritoneal dialysis. And then your intermittent peritoneal dialysis, it talks about that calls for 30 to 40 exchanges a week. They have these 30 to 60 minute exchanges. So it just kind of talks about the different types of peritoneal dialysis, which honestly, I didn't even know existed until I taught this class. Complications of peritoneal dialysis. You can have peritonitis or an infection there, and catheter infection, an infection of your peritoneal cavity. Abdominal pain. You could also have hyperglycemia or increased triglyceride levels. So with the peritonitis and the catheter infection, we would obviously watch for confusion or fever, if there was redness or swelling at the site there where that catheter's at. If you had cloudy drainage that came out of there, that could be an indicator of peritonitis. Um, Hyperglycemia, this is from the glucose in the dialysate being absorbed into the bloodstream. Um, Abdominal pain and distension can occur. Sometimes this pain can also happen from the tip of the catheter resting against the bladder or the bowel, the peritoneum. You can have accidental infusions of air. There's a lot of things that can happen there. I told you they could have increased triglyceride levels. This is because of the continuous absorption of glucose. This results in increased insulin secretion. And when you have that, that stimulates your the hepatic production of triglycerides. Dietary and insulin administration modifications may be necessary because of this. You can have protein loss, so the peritoneal membrane, because of of how permeable it is to plasma proteins, amino acids, things like that. It can result in excessive protein loss. So it goes on to talk about a positive nitrogen balance can be maintained with adequate protein intake. Okay, we are done with that. So we are going into renal cancer now. So just a few slides on renal cancer. So renal cancer or kidney cancer is one of the most common cancers in the United States. Risk factors, tobacco use, family history, obesity, hypertension, exposure to carcinogens. A lot goes on to talk about it's malignant more times. It's more common than benign tumors. Um, Patients are usually asymptomatic initially, and then they can start because of these tumors that they start having and causing problems with the renal structures. They can have this, what they call this classic triad, which is flank mass, flank pain, and hematuria. So our medical management then for diagnosis, you would have, oops, let me change the slide. For diagnosis, you would have ultrasound, angiography. They could do percutaneous needle aspiration, CT scan, or MRI. And then medications, you can have for treating this, you would have biological immunotherapy. There could be surgical management, which would be a radical nephrectomy, and that would involve removing the entire affected kidney. So a lot of times that is what they end up doing, is this radical nephrectomy or removing the entire kidney. Metastatic renal cancer says only has a survival rate of 3 to 10% at 5 years. So it says with early detection, renal cancer has shown a 60 to 70% 5-year survival rate after undergoing radical nephrectomy. So removing that entire kidney. Let's go on to renal transplant. So with renal transplant, this is again end-stage renal disease. This isn't a cure. Once they have renal transplantation, dialysis is removed. They won't need it any longer. It says there are dietary and fluid restrictions not eliminated, but they are reduced. They do have to remain compliant with lifelong treatment. That's very important that they understand that they will be on lifelong treatment. There's some parameters there. It says they have to be in good health, ages 5 to 50, have the best outcome. So some contraindications include untreated or metastatic cancer, refractory coronary artery or heart disease, and psychosocial issues like drug abuse or psychiatric disease. So pre and post procedure, pre-procedure talks about how the client usually receives dialysis within 24 hours of surgery, prophylactic antibiotics, of course, immunosuppression therapies and antibodies. And then the big one here is your post-procedure is your risk of rejection. So you can have hypertension that's associated with rejection, renal artery stenosis, renal vasoconstrictions. So if you think about this risk of rejection, you can have this accelerated rejection, which occurs in 2 to 4 days, or you can have this hyperacute rejection, which occurs in minutes or hours after they receive the graft. But both result in graft failure and the necessity for graft removal. So acute rejection, the most common and treatable form, occurs like 3 months after the transplant, during the first 3 months after the transplant. Clinical manifestations that you would need to be aware of would be for acute rejection would be a fever, swelling, if they have tenderness or pain over the graft site, obviously decreased urine output or urinary retention, electrolyte imbalance if they start complaining about palpitations because maybe they're having electrolyte changes, a rise in their serum creatinine level could indicate this. So increased doses of immunosuppressive medications are used to manage episodes of rejection. Chronic rejection is another primary cause of graft loss. And a lot of times with this chronic rejection, you're going to see the hypertension, proteinuria, and a progression of renal failure. So obviously they're going to be watching the creatinine and lab values. So can a patient show signs of rejection months after the transplant? Well, I just said that they could. So yes, acute rejection is up to 3 months post-transplant. And I did talk about different signs and symptoms that they would see for that. Tachycardia, palpitations, hypertension, fever. Maybe they're retaining fluid, so weight gain, change in their labs, increase in their, BUN and creatinine. They start having a decreased urine output, retention, flank pain. I said pain over the graft site. Interventions post-transplant. A big one is that these guys are going to be on immunosuppressive medications for their life. So we really need to stress the importance with that. So, but in Initially, though, interventions post-transplant, obviously, we'd be monitoring their vital signs, their pain, looking at their incision. We'd be monitoring their renal function tests. If they have poor renal function, that could indicate rejection, and then monitoring their INO. Urine output may be increased due to the improved clearance of BUN, which acts as an osmotic diuretic, and because of IV fluids receiving in the operating room. So just be aware of that. Okay, now we're going to talk about renal trauma. So with renal trauma, there's different grades there, 1 through 5. You can read like what that entails. A lot of times this can be due to a fall. They can have some type of motor vehicle collision, sports activities, gunshots, some type of traumatic injury of the abdomen. And they can have a contusion. So the extent of the injury just depends on what's going on. So most of these accidents involve males less than 30 years old, and it's usually because of blunt force trauma. We would always, if you had any of this trauma occur, we're always thinking, they're going to probably be showing a lot of hematuria or blood in their urine. That's usually actually an expected finding. Obviously, we would be watching it and monitoring it. But the most important thing, since the hematuria is expected, and not always does that mean, like if you have only a little bit of blood-tinged urine, that doesn't mean, oh, I have not that bad of an injury. And if I have a lot of blood in my urine, oh, I have a really bad injury. That's not what that indicates. It doesn't indicate how bad the injury is. So hematuria is usually an expected finding. But what we really want to be monitoring with renal trauma is, again, the urine output, your vital signs. So if a patient, because you could actually have, because of this bleeding, you could have a clot form, and then you have an obstruction and your urine drops off. And that would be a big, big problem. So you have to really watch your urine output. That's your big key takeaway here is monitoring the urine output, not necessarily how much blood is in the urine with renal trauma. So diagnosis and treatment, here it says diagnosis, CTs, ultrasounds, MRIs, renal arteriography. So initial treatment, we want to control the bleeding, prevent shock, and make sure we're draining urine. Like I said, we're watching the urine output. We're monitoring pain. This is important. It can tell us if there's something going on, if there's an obstruction, if they start complaining of flank pain, there could be an obstruction or urethral colic or something. A lot of times they just watch and observe, but surgery may be indicated, especially if there's severe bleeding. But a lot of times they just watch. So our nursing interventions, again, monitoring our vital signs, watching pain. Again, like I said, urine output and color, but the amount of hematuria does not correlate with the injury severity. So more important would be urine output, because I said oliguria may show that there's some type of obstruction that's happening. Our lab values, urinalysis, renal functions. Remember to watch your H&H so you can see if you're bleeding. We want to really help tell our patients that they need to rest. Okay. Now we're going to move on to our GI here. So overview and anatomy of the GI, obviously our mouth, esophagus, stomach, and liver. With the liver, we have absorption and metabolism of nutrients, degradation of toxins, hormones, and medications, and synthesis of proteins, clotting factors, albumin, fibrinogen, prothrombin. When I think of the liver, I think of bleeding. So, because that's where all your clotting factors are at. When you think of a disease process or organ, think of what your biggest problem would be. With kidney, our biggest problem would be high potassium because they die from it. So with liver, I think bleeding because of the lack of clotting factors or impairment of it. Onward, continued of your gastrointestinal system here. We have your gallbladder, pancreas, small intestine, and large intestine. So your speaker notes talks about what those organs do. It's review for you. Okay, so with any of these, kind of want to talk a little bit about an acute abdomen. So this would be if someone was having some type of hemorrhage that was happening. So it talks about here, you could have like a perforation. So you would be watching for acute pain. So it's very, very important if you have abdominal pain that we just really try to figure out what's going on because of things that could happen. If you have a perforation, a lot of times they'll show with sudden, intense epigastric pain, a rigid abdomen, or the abdominal muscles will be very rigid. Or it might be something totally unrelated, but you need to make sure you really evaluate thoroughly, especially if something that's in a very acute onset. So hemorrhage is a huge complication, or upper GI bleed. It's bleeding that starts in the esophagus, stomach, or duodenum. A lot of times you can see vomiting of red blood or coffee ground emesis called hematotemesis. If they have a black tarry stool, that would be called melena. So any frank bloody emesis indicates some type of moderate to severe bleeding, while hematotemesis suggests limited bleeding. Obviously, if somebody's having bleeding, they'll be displaying tachycardia, orthostatic hypotension, decreased skin turgor. Treatment for GI bleed is fluid resuscitation, administration of PPIs. Another thing that might see them administering is sandostatin for GI bleed. So red blood cell transfusions. So if you're having bleeding, they're going to be giving blood products with this GI bleed. It's very important if they're transfusing blood products that after the blood products are given, that they recheck another H&H. When I talked about sandostatin, the other name for it is octreotide. So this is used to help with, especially if you see like esophageal varices, if they have that upper GI bleed, like esophageal varices from liver problems, like liver failure, then they'll be administering sometimes this octreotide to help reduce the portal pressure. And then hopefully reducing the risk of esophageal bleed. So again, if you're transfusing blood products, then after you're done transfusing them, it's important to recheck an H&H to see how we're doing here. It'll tell you things like usually, if you give 1 unit of blood, you should see your hemoglobin rise by a gram. So if we're not seeing that, then that would make me think I'm bleeding still somewhere inside. But you do need to monitor the response of treatment to evaluate the effectiveness of the transfusion. So you should always recheck an H&H. So if you have somebody bleeding like this, obviously we would need to, besides monitoring our vital signs and our clinical manifestations of hypovolemic shock, we'd be wanting to make sure they have 2 18-gauge IVs and giving fluid resuscitation with normal saline until we could get blood products in them. We would be preparing for some type of endoscopic evaluation or x-rays as needed this entire time while this is going on. This slide just shows, it talks about complications of peptic ulcer disease, but you can see here it talks about GI bleed, penetration, perforation, obstruction. So all of these are very, very important and indicate like an acute abdomen. So I did go ahead and throw this slide on here. It talks about how with GI bleed, it can be sudden, severe, without warning. So you can read on here and read what the different types of bleeding that can occur or abdominal problems. Okay, so on to the liver. We kind of talked a little bit there about portal pressures and things like that. But so the liver, it says here, includes blood storage, blood filtration, production of bile, synthesis of clotting factors. That's their ding, 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 ding ticket right there. Prothrombin and your factors, removal of clotting factors to prevent clotting. And it also says metabolism of carbohydrates, fats, and protein. It also detoxifies the blood and storage area for vitamins D, E, A, and K, your fat soluble vitamins right there. So let's go into cirrhosis. So cirrhosis is a chronic disease, destruction, and fibrosis or scarring of your hepatic tissue. You have liver cells that die and they start to form these nodules that are surrounded by this fibrous tissue. And this results in necrosis of your liver cells and altered function of your liver. So cirrhosis, you have some risk factors there, viruses, alcohol, chronic hepatitis B and C. It goes on to talk about biliary disease, accumulation of fat in liver cells. And then I just want to kind of mention NASH, which is non-alcoholic steatohepatitis. So NASH, a lot of times you'll find this in obese patients, and it's accumulation of fat in liver cells, which leads to inflammation and cirrhosis. Has nothing to do with alcohol. So clinical manifestations, you can read through that and see it's a lot of different things that can vary from shortness of breath to jaundice, enlarged spleen, elevated liver enzymes. You have this increased risk of bleeding, and that's the big thing with liver. Thrombocytopenia, prolonged PT, elevated ammonia, another big, huge one for liver problems. This elevated ammonia causes a change in LOC, change in motor function, hyponatremia, and this asterixis. So that's like a flapping tremor in the hand. When you extend your wrist, then their hand will flap. So asterixis, this is important to watch for because this will tell you if your ammonia is increasing. So it's correlated to your ammonia level, which can cause somebody to become obtunded. So the big thing in here is avoid medications that can increase risk of bleeding when you have any problems with your liver. So we would be avoiding things like aspirin, NSAIDs. Always think bleeding with the liver. So here's some different lab tests. The big thing on your ALT, AST, bilirubin, things like that, that's found in a CMP, comprehensive metabolic profile. It is not found in a BMP. So if you're wanting to see your liver enzymes, you need to get a CMP. So you would have elevated AST or aspartate aminotransferase, and your ALT, your alanine transaminase would be elevated. Also, your bilirubin. I already said serum ammonia levels, decreased albumin. A lot of times, these clients have a lot of itching on their body. Their hands and their feet because of the accumulation of bile salts under the skin because it cannot be processed by the liver. This slide here just kind of shows the different things that can go on with having problems with your liver. So says here, you can have your hepatic encephalopathy there in the head, shows about behavioral changes, flapping tremor, which I said is the asterixis, the restlessness, seizures, coma. And then because of this portal hypertension, which is this backup because your liver is so hardened, then you can have splenomegaly, dilated abdominal veins, ascites, varices. They can have esophageal varices and rupture and have bleeding. So diagnosis of liver, the most, mostly they'll be doing CTs, EGDs, but also they can be doing these liver biopsies. So obviously with a liver biopsy, it would be crucial to know what your bleeding times are before you send your patient off to have their liver biopsy. It'd be crucial. When these patients go and have a liver biopsy, this is done with some sedation. They're put on bed rest for several hours because of the potential for bleeding. A lot of times they'll put either like a 5 or a 10-pound sandbag over the biopsy site, or they could even have them, the patient lying on the right side, and they have to lay on this right side lying position for several hours. Again, they are, they tell them to stay in bed. Other things that they can do for treatment of portal hypertension, besides giving vasoactive medications, they can do procedures, endoscopic procedures, such as banding and sclerotherapy. This is banding involves placing bands around the varices, the esophageal varices, to block the bleeding, and sclerotherapy involves injecting a solution into the bleeding varices to shrink or stop the bleeding. It goes on to talk about Blakemore tube. You don't really see those much. Okay. Complications, patients with cirrhosis can develop hepatorenal syndrome or HRS. This is, they have this renal or this, obviously this hepatic problem going on, and then they have a rapid deterioration of their kidney function as well. Mortality rate is extremely high with HRS or hepatorenal syndrome. And really the only treatment is liver transplant. They can also be at risk for spontaneous bacterial peritonitis or SBP. This is peritonitis in the abdomen. It can occur with patients that have chronic cirrhosis. They would have fever, abdominal pain, encephalopathy, and obviously hemodynamic decompensation. They would do a paracentesis to diagnose spontaneous bacterial peritonitis. And then also these patients have a risk for hyponatremia. Another risk for these patients or complication is a risk for DIC, which is disseminated intravascular coagulation. It's when you have small blood clots that form within the blood vessels, and these little blood clots these microemboli go all over the place to organs, disrupting blood flow to the organs, and end up causing organ failure. So you have this disruption in normal coagulation, and you also have an excessive amount of bleeding. So a lot of times you have bleeding from your GI tract, your lungs, wounds, skin punctures, anything. DIC is this bleeding, this disruption in this clotting process, but also you have lots of microclots. These patients will have a prolonged PT or prothrombin time. Here's your different stages of hepatic encephalopathy. Again, I talked about, if you see in here, it talks a lot about this asterixis. This is that flapping tremor of the hand when the wrist is extended. And the way we treat hepatic encephalopathy is by giving lactulose. Lactulose is a medication that we give orally, or we can put it up their rectum, and they poop out the ammonia. So hepatic encephalopathy, characterized by numerous disturbances of the CNS, changes in motor function, alterations in LOC. It's staged based on the severity of the presentation. And the main cause, like I said, is the accumulation of ammonia and toxins in the blood that are normally detoxified by the liver. Next slide, we'll be talking about ascites. That looks extremely painful. Accumulation of fluid in the abdomen, protein-rich fluid in the abdomen cavity, associated with poor quality of life, increased risk of infection, and poor long-term outcome. A lot of times this will go into pleural effusions for these patients. They have difficulty breathing. They will have weight loss, obviously, because you don't want to eat anything because of how much fluid you have here. They're jaundice, ascites. This is a late stage liver disease is when you're going to see this. These patients will be going in and having a paracentesis done. Clients are awake during a paracentesis. That's when they insert a catheter into the peritoneal cavity and they draw out the fluid. So obviously, if somebody was having this done, they would need a consent because it is they're inserting a needle into the cavity there. So they need a consent for that. They're awake, like I said, for the paracentesis. Sometimes they can sedate them, but they're still awake. And obviously, if there's inserting this needle, it would be extremely important to have the client void to reduce the risk of injury to the bladder prior to having this done. So here during the procedure, it talks about elevating the head of the bed. We help the client relax. You have a dressing over the puncture site. You explain the procedure. Um, we already talked about that they would void before having this done. Afterwards, you're going to monitor your vital signs. You're going to maintain them on bed rest, measure the fluid, send the specimen to the lab, weigh the client. These clients are on bed rest post-procedure because of this fluid shifting that can occur. They can be at high risk for falls. So treatment for patients with end-stage liver failure, a sodium diet that is less than 2 grams a day and low protein. A lot of times these patients will receive diuretics, and a lot of times they'll get spironolactone. We'll be obviously monitoring their blood pressure before giving diuretics. Talks about frequent paracentesis for the ascites. Obviously, we're going to be controlling and watching for bleeding. We would have these patients eat small, frequent meals to prevent this protein overloading and to reduce ammonia. A lot of times they'll give neomycin and lactulose. Not only do they receive spironolactone, they can get furosemide as well, but I'm just letting you know that they can also get spironolactone. What do you think? Should these patients be taking blood thinners? What do you think? The answer is no, not even aspirin because of the risk of bleeding. Liver equals bleeding. Surgery. Sometimes people that have ascites might need a shunt placed between the portal venous system and the systemic venous system to help reduce portal pressure. They could have liver transplants. Obviously, if somebody's having a liver transplant, then that would be, the nurse would be watching for, again, anything with bleeding. So we'd be watching for petechiae, elevation of prothrombin time. Always remember keep these patients checking their neurostatus, their vital signs, making sure they have a good airway. Remember your ABCs always. Nursing management. Um, Watching their abdominal girth, again, watching for bleeding. So your speaker notes kind of goes into this, talking about respiratory status, blood pressure because of the volume shifting, um, edema that can occur. Here it talks about bleeding gums, which, you have to watch the bleeding. So ecchymosis or bruising, epistaxis or nosebleed, petechiae, which is the small little round spots on the skin as a result of bleeding. Watch this stuff. And then if they end up getting a liver transplant, then obviously watching for signs and symptoms of rejection. So a lot of times, like right upper quadrant pain, changes in bile drainage, if they start having tachycardia, jaundice, fever. Okay, hepatitis. Hepatitis, there's different types of hepatitis. It's generally associated with individual behavior or exposure. There's several viruses, like I said, that cause hepatitis, and transmission is either through fecal oral contamination or directly through blood and body fluid exposures. So risk factors could be also include alcohol abuse, exposure to some prescription or over-the-counter medications, toxins, autoimmune diseases. There's acute versus chronic hepatitis, just depending on the time frame. If it's less than 6 months, it's considered acute. So it says patients who contract hepatitis B and C can develop chronic hepatitis that leads to progressive liver damage, and approximately 80% of all primary liver cancers. So having chronic hepatitis increases the risk of developing complications like cirrhosis, liver failure, or liver cancer. Clinical manifestations of this include abdominal pain, irritability, malaise, fever, nausea, vomiting. We'll be watching our AST and ALT, like I've already talked about, bilirubin, ammonia levels. They can also have jaundice or icterus or yellowing of the skin or sclera. Treatment, medications or antivirals, post-exposure prophylaxis for hepatitis A. There's interferon injections to help with viral suppression. There's vaccines and liver transplants. So education, we'd be talking about the disease process, lifestyle changes, no alcohol intake. We'd be discussing dietary restrictions, protein and sodium and fluid. Educate about medications that are metabolized in the liver, like acetaminophen and over-the-counter herbs and supplements. These can cause further liver damage, so they would want to avoid it. We would educate about diet, eating a well-balanced diet, having plenty of fruits, vegetables, whole grains to prevent malnutrition, and a low-fat diet. So low-fat diets, we limit the fat intake because the liver may not be able to make enough bile to process the fat. We would want to be teaching good hand hygiene because of the transmission from fecal oral route. So good hand hygiene before and after meals and after going to the bathroom. We'd want to treat or talk about avoiding behaviors like needle sharing, unprotected sex because of transmission, drinking from safe water, safe public water supply. Consider the water source and whether the public water supply is safe because of sewage. Infected fecal matter can transmit hepatitis A. So what are some priority assessments and findings? We would be thinking about fluid overload, and obviously we'd be diuresing these people, these clients. Do they have access to their medications? Can they afford their medications? Do they drink alcohol? Have they had recent travel? And then again, talking about good hand hygiene, unprotected sex, drinking from, or no unprotected sex, sorry, drinking from safe water supply. So liver cancer. So This just kind of talks about the different incidents of liver cancer. It says the mortality rates also have been increasing. Hepatocellular carcinoma is most prevalent. Secondary liver cancer most often metastasizes from the colon. So some risk factors, chronic infections, like I said before, with hepatitis B and C, history of heavy alcohol use, autoimmune disorders, chronic alcohol, and hemolytic anemia. Some manifestations, a lot of times they're asymptomatic until the liver becomes very enlarged. But abdominal pain, weight gain, weakness, fatigue, jaundice. So some late signs and symptoms like weight loss, jaundice, and ascites can occur. These patients, to diagnose this, they will be having different screens and ultrasounds, but a liver biopsy is what determines the stage of the cancer. So it's a liver biopsy. Treatment, chemo, radiation. There are some surgical options depending on the degree of liver function, but typically it says would be palliative for symptom relief of pain or distension. They may need a liver transplant, maybe an option. Usually surgical options are only palliative. We would just want them to try to stay as active as possible and eat low sodium, or I'm sorry, eat low protein meals and control their pain. Okay, liver trauma. This is one of your most vulnerable organs to trauma in the abdominal cavity because of its size and vascular structure. More common in males to have a liver injury. So this can include abdominal and retroperitoneal injuries, thoracic injuries. It says here that the mortality rate associated with concomitant injuries of the liver, abdomen, and head is approximately 70%. So from sports, fighting, motor vehicle accidents, blunt force trauma. So symptoms will depend on the level of trauma. So blood loss, hypotension, tachycardia. Shock may develop, including decreased blood pressure, tachycardia, tachypnea. You would be watching their level of consciousness. A lot of times patients may complain of right upper quadrant pain and have this guarding and rebound tenderness of the abdomen. A lot of times bowel sounds will be diminished. And then your diagnosis would be with CT scans, x-rays, obviously blood work, and management would be fluid resuscitation. It says here, evidence shows that almost 86% of liver injuries have stopped bleeding by the time surgical exploration is performed, and 67% of operations performed for blunt abdominal trauma are non-therapeutic. Therefore, a lot of times, because of that, they opt to just watch. So the primary concern for liver trauma is obviously, I said liver, you think bleeding, so the possibility of hemorrhage. So these patients will be on bed rest and obviously be moving very slowly, changing positions very slowly. Clinical manifestations for liver trauma are associated with the severity of injury and blood loss. Some common findings: tachycardia, low blood pressure, abdominal pain, So just kind of watch them and watch closely. And that is your recording for this lecture. Thank you.